So thank you for the organizers for the invitation to speak. I'm one of the pediatric oncologists from Children's National in DC, and I'll be talking about our MR-HIFU ablation trial in relapsed and refractory pediatric solid tumors. So we've had a lot of success in pediatric cancer over the past several decades, owing much to the advancements in supportive care, risk stratification, and intensification of therapy, which include chemotherapy, radiation therapy, surgery for many of our pediatric cancers. But this success has come at a significant cost, and the acute and late effects of our current multimodal therapy in children are quite substantial. And the success has not been shared across all cancer types, and the prognosis for metastatic recurrent solid tumors remains dismal and really has not improved over the past 3 decades. And this begs for the need for an improvement in our current therapeutic approaches in pediatric cancers, primarily more precise, less toxic therapies that will improve our outcome and overall survival. So we've talked about the advantages of MR-HIFU in this meeting already, the fact that it's completely non-invasive, there's no radiation involved, it allows for large volume ablation, it's a flexible system with local control over heating, which allows it to be combined with other applications, and it's been well tolerated in adults with minimal and minor reversible adverse effects. So this really makes it ideal for pediatric development. So we've put together a clinical trial of MR-HIFU for the ablation of pediatric solid tumors. This trial is coordinated by Children's, and it's also open at the Children's Hospital in Cincinnati. The system we use is Sonaleave system, and the IDE is held by Profound. The primary objective of this study is to determine the safety and feasibility of MR-HIFU with relapsed refractory primary or metastatic solid tumors in bone or soft tissue close proximity to bone. Our secondary objectives are to define tumor response in this early phase setting, and then also to evaluate changes in blood immune markers. This is done in collaboration with the Kaplan Laboratory at the NIH, and looking at quality of life and patient-reported outcomes, which is done in collaboration with Pamela Hines at Children's National. The key eligibility criteria is age less than 30 years. We did this to include many of our young adolescent and young adult population of sarcomas that are primarily taken care of in pediatric oncology. One must have measurable, histologically confirmed relapsed or refractory solid tumor, including desmoid tumors. They have to be located in close proximity to bone and be accessible to MR-HIFU for the target lesions. And then we have standard phase 1 eligibility criteria. Some exclusions are target lesions that are in the skull, spine, and any contraindication for MRI. The patient eligibility and imaging are reviewed by our HIFU multidisciplinary team, which includes a team of interventional radiology, oncology, surgery, radiology, anesthesia, and engineering. Selected patients that meet eligibility criteria and consent undergo MR-HIFU ablation of target lesion under sedation to a treatable volume maximum of 4-hour treatment time. This is done in the outpatient setting, and the patients are followed in the outpatient for 14 days post-HIFU therapy to evaluate for adverse effects. Subsequent treatment cycles are possible if patients have additional target lesions, incompletely ablated lesions, and also have no treatment-limiting toxicities and have recovered from any AEs from their initial treatment. This is one of the examples of one patient that we treated. Her tumor recurred in a previously radiated spot. She also had other metastatic sites. The patient had a history of Lee-Fermini syndrome, which is a tumor predisposition syndrome. And so the family actually sought out this clinical trial looking for alternatives to radiation therapy for local control. I'm going to be talking about the first 6 patients that were enrolled on this study as our cohort that was evaluated with the data lock prior to evaluation. The median age that was on our study was 14 years, ranging from 4 to 21. We had half females that were enrolled. The diagnoses were osteo, Ewing's, and rhabdomyosarcoma. We also had 3 patients with desmoid tumors. The tumor locations were varied. All 3 of our malignant diagnoses had metastatic disease, and all patients had prior therapy, as this was in the relapsed refractory setting. Many included chemotherapy, radiation, and surgery. All adverse events that were seen, again, the primary objectives of this study were safety and feasibility, that were at least possibly related to the HIFU treatment were mild. We had 3 patients with grade 1 pain, 2 patients with grade 1 skin burn, and 1 grade 1 paresthesia. These were transient and reversible by 14 days. We had no treatment-limiting toxicities observed. 2 patients underwent a second MR-HIFU treatment of another target lesion, and 1 patient underwent a second MR-HIFU of an incompletely targeted treatment lesion. Since our initial data evaluation, we've had 2 additional patients enrolled and 2 additional patients that underwent HIFU treatment of an incompletely treated target lesion. So in conclusion, MR-HIFU ablation of solid tumors in our pediatric, adolescent, and young adult population appears to be safe and feasible. Response changes and changes in patient-reported outcomes. Our immune biomarker analysis is pending. We've had challenges in recruitment for this trial, primarily due to tumor location, volume, patient positioning, patients with metastatic lesions seeking out systemic therapies. This trial has been open for quite some time, and the study is still continuing. We have expanded to enroll additional patients, so if there's any interest, we're happy to review imaging and enroll patients onto this trial. I'm also going to be putting in a plug for our phase 1 study combining MR-HIFU with lysothermosensitive liposomal doxorubicin, or Thermodox. This is the first in pediatric study looking at MR-HIFU in combination with Thermodox for patients with relapsed refractory malignant solid tumors. The NCT trials number is there, and again, if there's any patients for referrals, please contact me. My contact information is there. I'd like to thank the IGNITE team at Children's National, our NIH, Cincinnati, industry collaborators, and our funding mechanism for this study. Thank you.